A centerpiece of Medical Education Week, this program gives the recipient of the Brody Medical Education Award a platform for advancing ideas about the process and practices by which we make doctors and work toward healthful changes for patients, populations, and the public. These Brody Medical Education lectures have tended to be sharply original, deeply thoughtful, and deliberately provocative presentations, with the result that they and those delivering them have stirred us up, spurred us to think in new and adventuresome ways about medical education, about who we're turning into doctors and how and why, and what our graduates will do once they're out in the world. If past Brody Award recipients have been dynamic thought leaders and change agents in their respective roles and institutions, this year's is no exception. Paul Worley is Dean of the School of Medicine at Flinders University in South Australia. You'll find a short bio sketch in your handout. But here's why he's our 2016 Brody awardee. Dr. Worley has led the rapid expansion of Flinders University's rural-based medical education programs at both the undergraduate and postgraduate levels. His groundbreaking work in the science of rural community-based medical education and its impact on addressing the maldistribution of doctors for rural and underserved areas have changed the face of medical education and rural medical workforce policy in Australia, but also around the world. If medical schools these days are challenged to combine the best of biomedicine with new understandings of neuroscience, the learning sciences, and a sharpened focus on socioeconomic, cultural, and political determinants of health, Paul Worley can help us to think and to prepare to act in these new directions. 2, he can help us think about what it means to be a truly socially accountable and socially responsive medical school, and just what it might take for us to realize such an aspiration. I'd like to thank the Brody Medical Education Award Committee, led by Dr. Evan Heald, and the Department of Medicine, our partners for this program. And I'd urge you to please take part in other events during this Medical Education Week. There's an array of wonderful posters in the hallway just outside the library. And I think you'll be able to learn some things about the leading edges of medical education reform here at UVA. And now, without further ado, please join me in welcoming Dr. Paul Worley.
Thank you so much. Can people hear me if I say that? Put that a little bit there. Okay. Thank you so much. It is an honour and a privilege to be here on Jeffersonian land. I recognise the heritage of this place, and it is truly a privilege to be here. I also recognise that it is Monarchan land, and that I come from the land of the Kaurna people, the Aboriginal people who are still the custodians and the spiritual connectors with the land of the Adelaide Plains in South Australia. And I say that because the work that I want to present today and the future that I want to discuss with you is not something that comes from a blank slate. It comes from who we are and who has been before us. So I certainly want to recognise that. And when we think of who has been before us, if we think of medical education, we can't really ignore Flexner, the first multi-institutional medical education study over 100 years ago now, that really looked at integrating the modern sciences with the science of medical education. The founder of the 2+2 medical course, bringing medical education back into the teaching hospital, and really wanting to have the influence of modern scientific theory on medical education. But that was over 100 years ago. Since then, we've had a revolution in medical education which occurred probably from the 70s on under the influence of cognitive developmental psychology with Piaget and the social constructivist theorists, Vygotsky is one of them, that really led to problem-based learning as an approach to medical education, rather than the didactic approach of education that we are using here in this lecture theatre. But it hasn't stopped there. Closer to where we are now, we now have functional MRI. We now have the opportunity to look at neural pathways in real time. We have a neuroscience of learning, led by people like Norman Deutsch, the Toronto psychiatrist. We understand that our brains are plastic, and we understand that learning and education changes the actual structure of our brain. So how is that then being applied to medical education? And more than that, we have the organisational systems theorists, Peter Senge and the like, and those that have come from the health service to influence education, like Julio Frank, calling us to think about a system approach to medical education, and particularly the influences of economic and social systems on medical education, what Julio would term as social responsibility or social accountability. So our thought leaders have moved on from Flexner. Have we in medical education? Certainly someone a long time ago had a very profound view of what it takes to measure our worth. I'll leave you to read that there, but I emphasise particularly the last phrase. To increase your worth is not about what you have achieved, but who you have lifted up. It's not about what you have achieved, but who you have lifted up. Let me tell you about one of our students. Because when we're talking about social accountable medical education, in the end it's an outcome that actually matters. And there are many ways to get to that outcome that we can discuss. But I want to tell you about Sue, a city girl, who decided, as part of her medical education at Flinders, to volunteer for a new approach to medical education that we were starting in '97. And I'll tell you more about it during this talk. That was out in a small town of 2,000 people, and she spent the entire year 3 based in that town. At the end of the year, she was one of our top 10 students academically, having learnt in a small town and being examined in comparison with her peers in a major medical centre like this one. After graduation, she decided that she actually wanted to work with the Aboriginal people in Australia and train to be in the Flying Doctors. And so she trained in obstetrics and anaesthetics and rural medicine. But while she was in her training, she received a call to go and work somewhere where other doctors were not working. In fact, even the local doctors were not working. And that was in the south of Sudan. She was given a great privilege when she went to the south of Sudan, because the thatch hut that she was given to live in had a dugout area. That was where she slept. Why was that a privilege? Because that meant that when the armies came through at night and strafed the village with their machine guns, the bullets would fly over where she was sleeping. Not everyone was that fortunate. Some would say that there was something different about Sue just because she went and worked there. But she emailed me from there. They did have email access in the south of Sudan. And she asked me, Paul, have I done the right thing? The question revolved around a patient who had been brought in by their relatives. And instead of the jet black skin of a southern Sudanese woman, She was more my colour. Sue had the head knowledge to be able to diagnose what was going on. This lady had delivered a baby a week before. She had not delivered her placenta. She had hemorrhaged. She had the hand knowledge, the skills, to be able to deliver that placenta, to be able to fix the lacerations that had occurred. But she knew that despite that, this lady would not survive if she didn't have a transfusion. And so what she did next was why she emailed me. Because she lay down in the bed next to that lady, put a needle in her own arm, took off a litre of blood and gave it to her patient. And she said, "Paul, did I do the right thing? Did I get too close?" In the end, we can have all of the theorists about medical education, but what really drives medical education is actually patients. Both our desire for care and their needs. Of course, some patients are far more vulnerable than others. A beautiful picture of an intrauterine operation correcting a defect before birth. And we know that some patients are disadvantaged compared to others, because if there is no access to healthcare, there still is plenty of access to cemeteries. We also know that in every country, this is Australian data, but it is equally true for North America, that if you look at the baseline of 1.0 being the ratio of doctors to patients in cities, as you get more and more remote, the ratio gets worse and worse. And that is a constant whether you are in Bangladesh or whether you are in Virginia. And we know that even within cities, there's incredible disparities of health outcomes. This work done by Michael Marner causes us to pause and think about why there can be a 10-year life expectancy difference between two suburbs in one city. And more importantly, an even greater disparity in healthy life expectancy. Tudor Hart put it very carefully and very succinctly when he said, the access to care varies inversely with the need for care, particularly when you're looking at the Millennium Development Goals 4 and 5 around maternal and neonatal health. And a Russian put it, I think, very succinctly and very profoundly for us who are part of major medical centres. No matter how far our country may advance in medical science, if that science be available to only a select few, that country cannot take pride in its medical progress. Fred Hollows is an ophthalmologist in Australia who has shown that you can undertake a lens extraction and replacement for less than $7 Australian. Imagine the impact on health money for the disadvantaged if all of the additional money that we are currently paying for lens extractions was actually able to be diverted to areas of unmet need. Little wonder that from the public's view, there is a problem of trust. There is a problem of trust in our health services, in our clinicians. One of the reasons many people are seeking alternative clinicians to doctors for their care. And there is a problem of trust in our education processes for how we are graduating doctors that are becoming part of a system that people are less likely to trust than they were before. So, our roadmap for today. Firstly, a very brief academic rationale for socially accountable medical education. Then using Australia as a case study. Be careful. As a case study, you have to be able to say what of that applies here and what of that doesn't apply here. Then some WHO imperatives and initiatives that are taking up social accountability for medical education. and then some brief reflections on history. So, I think I've laid out a challenge to medical education. There is a crisis of trust. There is a maldistribution that medical schools may be part of creating. So how can we respond to this challenge? And the answer, as always, is to look at what is the evidence. And let's use the evidence, the science, to guide our change. So, what is the science? And firstly, I'll draw on the science that we understand around rural communities, but it really is about underserved. So where you see rural, read underserved. And the first thing is that we know that if you recruit students from a rural or underserved origin, and you then provide positive and extended undergraduate, by that I mean ND, experiences, then you are far more likely to have people who choose rather than are compelled to work in rural environments. So it works like this as a pipeline. You need to work in rural high schools to first of all raise the aspiration that I might be able to be a doctor coming from an underserved population. You then need extended and repeated rural community-based medical education. I can provide all the references for this if you like. You then need excellent residency education, again, in those areas that are underserved. And you then need continuing medical education for those doctors who move there, because they need to stay up to date. And doctors aren't fools. If they know that they're going to go to a place and they're not going to be able to keep up to date, they won't go there, or they'll very quickly leave. Put all of that in place, and you get a virtuous cycle where those excellent doctors then become the recruiters and the trainers and the teachers of the next graduates. So there's evidence around, from the medical workforce point of view, that we can change medical education to be based in underserved areas rather than our traditional venues, and it will have an impact on the social determinants of health. But there's more. There's changes in medical education that we have to take into account, and particularly the challenges that I outlined to start with around the relevance to society, and also some of the emphasis on generalism, which I'm sure is coming through the States as well as it is Australia. Firstly, the relevance to society, and this is where the term social accountability comes into. And I'm taking the definition from the Training for Health Education Network, VNet. That's the framework. You can look them up on vnetcommunity.org. And what they define as social accountability in medical education, it's an obligation to direct education, research and service activities, not just education, towards addressing the priority health concerns of the community, the region, and or the nation they have a mandate to serve. It begs the question, who is your community? The question in the old book, Lord, who is my neighbour? When someone was trying to get out of a commandment. What about who is our community? And those priority health concerns are to be identified jointly by governments, healthcare organisations, health professions and the public. In other words, the curriculum is not something that the medical school develops, it's a joint enterprise. The implementation of the curriculum is not something that is done in isolation, it is done in collaboration. This has been taken up more recently by a global consensus of a number of bodies on the World Federation for Medical Education is one of the signatories to this document about social accountability in medical education. And if you are interested in an article, Roger Strasser from Canada and myself and a number of authors from around the world put together an article around community-oriented, community-based and community-engaged medical education, which gives some of the tic-tac details, the how-to. But there are other issues around generalism that need to be thought about in terms of our medical education. And a lot of this research has come from the States. Barbara Starfield's work that shows every graduate that we produce that goes into primary care is going to be decreasing the morbidity and mortality of the population they serve. The same can't be said for every graduate we put into subspecialist care. This is not a conjecture, this comes from the data. Her presumption about the data, why is this so, is that there is a level of over-servicing that occurs that causes side effects. Now that's a presumption, that's a hypothesis. What is clear is the ratios. The more specialists, no increase in health outcomes. The more primary care, there is an increase. If we are to be judged by health outcomes of our society, that causes us to pause. The third area around this area of generalism and relevance is what our students are asking for. I've heard here, we have students who are so passionate and so excited about seeing meaning, being able to have the agency to make a difference in patients' lives while they are medical students. Not 4 years before I can make a difference, but actually to make a difference while I'm a medical student. And these are just some of the examples that I've heard of here. So there's a whole change of events around medical education that's causing us to look at underserved communities. Then there are changes to medical practice. In particular, this work again was done in the United States and it's been repeated in the 21st century. If we look at the number of people in a population being 1,000, 750 of them being ill, 250 of them in any month going to a doctor, how many come to the UVA? 1. So it's a bit like trying to say we want our students to learn about these people, but we're only ever going to expose them to that one. The case mix has changed. When Flexner put forward his thesis, all of those patients were coming to the hospital because that's where the care was. Care has changed. Medical practice has changed. Have we changed our venues to go along with that? So there's a change in practice that is driving us to areas outside of our traditional venue. There's also, though, a need for medical research outside of the major medical centre. As a rural doctor, it wasn't much help to me when a patient came in with a head injury to know that the evidence base around management for that was that they needed to have an MRI within 30 minutes of presentation. I did not have an MRI. So what was the gold standard for practice where I was? I couldn't go to the tertiary hospital to find that out because they didn't know. They did know what was the gold standard for their context. They did fantastic work for that. But in order to get evidence to improve practice in underserved areas, we need research to be conducted in underserved areas. We need the medical school to be in underserved areas. One of the ways we get the medical school to be in underserved areas is to teach in underserved areas. Our teaching and research is mixed. We thus create an evidence base for quality improvement of practice in the majority of the world that is underserved. All of these things together actually produce what Jefferson was about. It's about economic and social capital and cohesion. And don't we need that? If you look at our world today and you look at the dilemmas that I face in terms of the risk of travel to different countries and having to do risk assessments at my institution, can I go there or can't I go there? All of those things, it all gets back to this. So what opportunity do we have as medical schools to actually be part of that solution? Let's look at the case study. An Australian government response. What it did, quite simply, was it supported more and more diverse medical students. It located medical education and medical schools, but not just medical schools, and research in underserved areas. And it provided support and infrastructure to health services and clinicians. So let's go into a bit more detail so you understand what we did. Firstly, this is the change in the number of medical students per year in Australia. Going back from the 70s when it was about 1,000, it's over 3,000 now. So we've trebled the number of medical students, recognising that we were actually underserving and relying instead on recruiting doctors from poorer countries who needed the doctors more than Australia did. It was a moral outrage. I'm not sure if that happens in the United States. What we also realised, though, was that if we just took those students and taught them in the same way, we'd get Starfield's outcome. And that wasn't what we were looking for. So where we taught actually does make a difference. We started our program at Flinders in an academic health science centre. All the research, all the labs, all the teaching, all the education. In fact, we even had dormitories. You could basically live your whole life inside the medical centre. Do your undergrad, your residency, you're attending, it was all there. Our Adelaide campus, it's about 40 years old now, beautiful place. We have about 160 students, use problem-based learning, it's a 4-year MD program, you would recognise it well. We have the basic science emphasis to start with, the clinical science emphasis, but there's integration the whole way. So I think you'll recognise who we are. We started just with tertiary hospitals in the city. Very soon, though, we built a network of other health services around the country in all of these locations. Darwin, which is 3,000 kilometres from where we started, it's a tropical centre. We now have the opportunity for our students to undertake their entire MD based in this underserved area with a large Aboriginal population in Darwin. The Riverland campus is about 300 kilometres from Adelaide. It's a small rural area on the River Murray, agriculture through irrigation. Mainly family docs, but some specialists. We have another site about 500 kilometres south of Adelaide. We see that as one of our close sites in our context. More specialists, but again, mainly generalist specialists. So all told, our campus, or as you would put it, the grounds of Flinders Medical School, is now transcontinental. In fact, if you map it on the United States, it looks something like this. So that is the community that we have not chosen, we have been asked by that community to provide an outcome that is going to help their health. So far from just Flinders University being isolated because of all this stuff, in actual fact what we've found is that a whole lot of networks have formed. And Flinders University has actually grown in influence, not diminished in influence through all of this, this confusion, you might say. In actual fact, what we've done is instead of having an academic science centre, we now have an academic science network. And of course, it's academic health science networks that are actually this century's construct. Last century, academic health science centre. This century needs to be a network to actually be able to put in place what we want to put in place. So, the question then comes, how did we do this? What was the powerful idea? What were the forces behind this? And as many of you may know, sometimes the most powerful ideas come from the most unlikely of places. This is the jail cell that Nelson Mandela constructed a lot of his theory about change and where South Africa needed to head. Our powerful idea came from this place. That's our health science lecture theatre in Adelaide. We're a coastal town. We get beautiful sunsets. I enjoy them. The critical innovation was to get underserved areas into the area of the medical course that had the most power and influence. And for us, that was Year 3. Year 3 was a set of rotations like that. We couldn't mimic that in a town of 2,000 people. You can't learn enough surgery in 6 weeks or 8 weeks in a town of 2,000. But if you turn that curriculum on its side, don't lose any of it, but allow students to learn all of it together over the year, I knew, because I practiced there, that there was enough surgery over a year, and there was enough obstetrics over a year, and there were enough paediatric patients over the year. So we had an opportunity to be able to demonstrate to the students and enable the students to learn the entire curriculum as long as they were there for a year. The question that was asked of us though is this actually second-class medicine? Are you getting these doctors trained by barefoot doctors? Essentially by people who couldn't make it in the city. So we studied it as an educational experiment, as you would do. This is what we found. This is a study that we looked at a number of years, comparing the scores in year 2 before the students split into the different venues, and then the scores at the end of year 3 after they had undertaken their different venues. You can see on the left at Flinders Medical Centre, the Academic Health Science Centre, there was hardly any change in the scores between years 2 and year 3. Our exams were pretty well calibrated. In the PRCC, which is our underserved area, there was an improvement of 5 marks out of 100 between those students' scores in year 2 and their scores in year 3. And Darwin, which is a hybrid approach, there was an improvement, but it wasn't statistically significant between either of those two. So we'd first proven that we were not doing any harm. In fact, we started getting students wanting to volunteer for this, not because they were interested in serving the underserved, because they wanted to get into residency programs and they wanted to improve their marks. And importantly, what we did was we destroyed the myth of the barefoot doctor. We were able to recognise that doctors in rural areas and underserved areas are different to doctors in academic medical centres, and both can be brilliant, and both can be brilliant teachers. We've since replicated that in other areas. The red bars are an urban underserved area that we now teach in, compared again to our academic medical centre in blue, and these are looking at the end of year 3 scores, which again show improvement each time. So we asked the question, why is this happening? Is it just some quirk? Is it something in the water? Is it that the students are trying harder in these environments? Well, I never knew a medical student who didn't try hard in their exams. But we actually looked a little bit harder. And what we found was that the students, paradoxically, were actually getting greater clinical contact when they were in the underserved areas. They were being invited into the lives of their patients at a much greater depth and breadth than the students who are unfortunately having to observe a lot of care in the tertiary hospitals. So they were choosing to engage in clinical services a lot more. Even more striking was when we asked the students to value what they were doing every 15 minutes of the week. And we got them to keep logs for 3 weeks of the year, beginning, middle and end, and how important was this last 15 minutes for your education in preparation for the exams. What I highlight there is that the students in the tertiary hospital said they were better off being home. They were better off being home, studying. The students in the underserved area actually saw value in what they were learning with the patients. For those of us who believe that it's actually being with patients that makes a doctor, you can understand why in these underserved areas they were improving their marks. And I have to say that the education that was occurring in our academic medical centre was regarded by the Medical Council as gold standard. I'm not comparing some sort of slum with an all right sort of environment in the country. This was what was considered gold standard. And importantly, what we found and what David Hirsch and Ed Krupat and others have found was that in this environment, the students' orientation to the social aspects of medicine, to understanding their patients as people, actually was maintained rather than them becoming more cynical, which unfortunately happens. So, what about the supervisors in this environment? What we have is we've developed a number of models of consulting in community-based medical education. In some, the student is outside the doctor-patient relationship. So the doctor and patient go at it, the student observes. That's student as an observer. Then you can have the doctor as a healer, where the doctor is actually teaching the student and they're looking after the patient at the same time. But there's really no interaction between the student and the patient. Then there's the doctor advisor, where the student is with the patient and the doctor advises the student on their care of the patient. And then there's the doctor as the orchestrator, where there is a student-patient relationship and the doctor is orchestrating that. Why do I say there's a student-patient relationship? Because in these underserved areas we've built clinics so that the students can have rooms where they can see their patients at the same time as the doctor is seeing patients, and the doctor can flip in and out. that there's actually room for that to occur. So there's an investment that's occurred. What do we then find about the workload on doctors? I don't know what you find, but what we hear is, I can't have any more students because they just take so much time. I'm getting worn out by all the students that I have to teach. So this is what we found. We found that that was exactly the case for the first 6 weeks. But then, students started to get to know the system, and they started to actually understand and be part of the team. And then they went past that and actually enabled the doctors to see more patients than they would have otherwise. So if we had stopped at around the 3-month mark, it would have been a break even. But because these students were there for 12 months, what happened at the end of 12 months is the doctors said, where's my student gone? How am I going to cope? They were like a resident. They became part of the team. Is it any wonder that the doctors, when we interviewed them in the hospital, felt that students were just like a merry-go-round, coming and going and coming and going, and I never got to know any of them. In fact, they all sometimes felt like they were almost artificial facsimiles of people. Whereas their experience in the underserved areas where they were there for a whole year was that they were able to take them through the journey of learning and actually enable them to get some autonomy whilst they were still there. So, did it work for the reasons we were trying to do it in terms of serving the community? 7 times the number of our graduates chose regional, rural or remote practice than those from the tertiary hospital. Twice as many were likely to choose primary care. But importantly, not all. That environment was a great place to learn to become an anatomical pathologist, to become a neurosurgeon, to become an oncologist. We've had all of those disciplines come out of that learning. And they've come out of that learning to practice those specialties in a different way. We also know that this sort of investment by universities in underserved areas directly benefits the economy of those areas. So it starts bringing those areas up out of their disadvantage. We know that there is actually an optimism that comes in a community when they have a medical school presence there. If we have a medical school, if a medical school trusts us to be training its doctors here, what else can we do? What other things can we think about? And we know that actually being there actually mobilises some of the existing social capital that is there. It's not all an implant, it's actually a revelation of what's already there. So what have we done at Flinders when we've looked at these outcomes and we've looked at these benefits, and the clinicians in the tertiary hospital are saying, we want some of this as well. We want to have those benefits. And the students are saying, we want these benefits. Well, what we've done is we've gradually, step by step by step, increased the number of students who are getting this type of education, such that next year all of our students will have that education. That's taken us nearly 20 years. It's not an overnight thing. And it's been done as students and staff and communities have demanded it. So that's an understanding of what's happened in Australia and some of the outcomes. But this is not just an Australian issue. The WHO recognises that it's actually a global issue. They have put out a manuscript around transforming and scaling up health professional education. I'm sure you realise this, but there is a shortage of millions globally of health professionals. We're not short a couple of hundred. It's not a marginal shortage. It's a major shortage. And therefore there needs to be ways of scaling up without reducing quality to be able to address the health needs of the world. After this document was formed, the WHO realised that in order to make things happen, they needed to get governments engaged. So what they've done, they engaged a group of us to look at having an evaluation toolkit that would go to governments, and the government could then evaluate at a national level its health professional education institutions about whether they were contributing to or actually contributing against universal health coverage. So what impact were the health education institutions having on universal health coverage? And this is coming down the turnpike. So this will be coming to the US, it's coming to every country in the world. So what did they find? First of all, they found that and the way we've put this together is there are some country level indicators, so they can look at it at a national level. Have you got quality? Have you got enough quantity? Have you got sustainability? They're the traffic lights that you can see there. I know it's small. You can have my slides later, please. Don't feel as though you have to get your glasses out. But what we've also done is said, okay, there are country level indicators, but there are also things that governments can use to look at the institution level, the building blocks, if you like, of health workforce education actually benefiting universal health coverage. And those firstly are around governance, policy and funding. Are educational institutions audited by the government on their workforce outcomes? Are they financially sustainable when they're delivering on those workforce outcomes? And is there collaboration between the different ministries in order for this to occur? In terms of workforce planning, do you actually know how many you need? Do you know where they are needed? And are the institutional enrolments and curricula reflecting those needs that have been determined at the country and the regional level? Then the standards, and this is an area where the US, I think, has led the world in many ways in terms of, do you actually have accreditation agencies? Many countries don't have accreditation agencies for their medical education. Does your student selection, another building block, actually reflect the reference population that you are accountable to serve? Does your faculty represent that population as well? Are there appropriate remuneration structures so that if people are encouraged to work in underserved areas, they can afford to do so? And do you know the career interest and outcome of your graduates as an institution? And are you looking at modifying your curriculum and selection on the basis of those outcomes? How is the community engaged in determining your curriculum and your curriculum delivery? And the locations of that in terms of community-based medical education and longitudinal integrated clerkships. So these are not the building blocks according to Flinders. These are not the building blocks according to Guatemala. These are the building blocks according to the WHO. And these are going to the World Health Assembly and to the WHO throughout 2016-17 and will then become the way that the World Health Authority reports to the United Nations on health professions educations across the world. It makes us ask questions about what we're doing, but it also potentially gives us some guidance. So, my thesis and my challenge to you is that the model of education that Flexner used in actual fact is the little bit of this hourglass. That there was a community engaged and community-based and socially accountable medical education for centuries. And for very good reasons at Flexner's time he said, that's crook. It's not helping. Quality is not there. So we need to do this. But we now live in a different technological age. We now live in an age where most of the information that the students will learn in their medical school is actually already here. So the head knowledge is already here. The hand and the heart knowledge, however, needs to be learnt in different environments to those that Flexner advocated for. So in actual fact, is Deutsch's and Frank's future far more like the Hippocratic future that we came from, and far less like the Flexnerian model that existed for 100 years. So my challenge to you is that some elements of medical education are eternal and beautiful, like this rock garden in Kyoto, and like my beautiful wife. However, some elements of medical education do need resuscitation. And perhaps, just perhaps, social accountability might be a plumb line for us determining which is which is eternal and beautiful, and which needs resuscitation. Your founder actually put a very good perspective on this. It is safer to have the whole people, respectfully enlightened than a few in a high state of science and the many in ignorance. I'm sure he would have said the same about the health of those people. It is safer to have the whole people healthy than to have only a select few. Perhaps in the end, the time has come for patients to reassert their influence on we medical educators and researchers. Because my thesis is that in the end, it's patients and their engagement and their ownership that is actually social accountability. Thank you.
Thank you so much. You've covered a lot of territory, but we have a generous amount of time for some conversation with you. And my sense is we have researchers, educators, students, and others here eager to engage with you with questions and comments about what we've heard and what it makes us think about. So we'll bring a mic to you if you have a question or comment, and please identify yourself before you ask your question or make your comment.
I'm Natalie May from General Medicine and the Phrenesis Project. I just want to know what happened to Sue.
Sue's working with the Royal Flying Doctor Service. She stayed in south of Sudan for a year, and she got burnt out, which is common in that sort of environment. And she's now working in the Royal Flying Doctor Service and loving her work. She's come back and spoken with our students. She takes students from another university because she's up on the northeast coast in rural Queensland. And she still has a cat.
Mark Socher with Emergency Medicine. How much telemedicine do you guys use in your rural, when you train them rurally, and do you rely on it, and just in general, how much do you go back to the mothership, as we call it?
Yeah, thanks. That's a really good question. So when we started in 1997, you can probably answer the question for me, because the information superhighway in Australia was an information dirt track. We didn't have the bandwidth. So we tried video conferencing, we tried teleconferencing. We ended up with videotapes and then CD-ROMs and now YouTube. What we said was that we wanted the education to be equivalent. And because at that stage, it really wasn't clear what was the curriculum on a 4-week rotation in internal medicine apart from being there, or a 4-week rotation in surgery apart from being there, we actually had to go and observe and record everything. So we did. We went and recorded it. We recorded all the lectures. And what that did was it started meaning that the students in the city no longer wanted to turn up, they just wanted the recordings. So telemedicine actually ended up getting used as much in the city as it did in the rural area. The way we look at it now is not as a hub and spoke model or a mothership and satellite model, but we look at it as a network model. So we actually recognise that some of the doctors in the rural areas have skills that the doctors in the city don't have, that all our students need to be aware of. The doctors in the north have an understanding of Aboriginal health in a much different way in tropical medicine that our students in the Mediterranean, Californian south don't have. So we now have curriculum led from all sites in the network, and we have the school led from all sites in the network. So the person who was in charge of our whole year 3 for the school was residing in Mount Gambier for 2 years, 500 kilometres away from Adelaide. We've had people leave year 4 from Darwin, 3,000 kilometres from Adelaide. So it's reframing it into a network and saying all of that network actually brings enormous value to our students and to our staff. In fact, we undertook this because we wanted to change. And we realised that by engaging with these other communities, it would change us. Yes, we would change them, and I emphasised a lot about how the medical school contributes to the benefit of those communities, but it's changed us as well. And all of our students get a better education because of that diversity. I'll just add while the next one's coming, we now have fantastic research programs in telemedicine and online delivery of palliative care and rehab services and psychiatry and all of that, because we've got this network around the place. So if you're looking at sites for research, you just come to us and we say, yep, we'll bring all of these people together and you can put them in for your grant. So absolutely, it's a powerful network for research and care delivery as well.
Hi, Jen from General Medicine.
Yes.
I have a question. So, do you have a difficulty to recruit the faculty, or in your schools, because most teaching happen in the rural area?
Yeah, so really good question, and one that we were very worried about when we commenced this program, because our experience had been allowing students to go to rural areas for 2 to 4 weeks with a practitioner. And it was very rare to find a doctor who wanted to have a second student in the year. So they would say, I'll take one student for 4 weeks, but I'm so exhausted after that, please don't send me any more. And here we were saying, we'd like you to have students for 40 weeks. What we found was that, and it was that diagram again, the sigmoid curve. Our experience had been, and the supervisor's experience had all been at the bottom part of that curve. Once a few of them took the risk, so we had a group that took the risk and said, you might be nuts, Paul, but we actually can see some value in what you're saying, and we're prepared to give it a go. They took the risk, and they, at the end of the year, were saying, where's my student? This is fantastic. Mm-hmm. So we then had other doctors coming and seeing this, not talking to me, but going and talking to those supervisors and saying, what's it really like? In fact, every time we've replicated a program, we've actually got the doctors from other programs to go and talk with the doctors in the new program, without us being there. So that they can say, this is really what it's like. I'm not having to impress the dean or do anything like that. This is the nuts and bolts. It actually is as good as it seems. So we've actually recruited a whole lot of people that previously didn't want to teach, because before it was just too hard work. The people we do get to teach, when it comes to the exam time, are just as nervous as the students. Because do you know what? They suddenly have some skin in the game. And we'd found that previously there was no skin in the game. Because there were so many different teachers, if a student failed, it wasn't my fault. It was someone over there in some other discipline or whatever. But if you're the principal supervisor for a year, you have an investment. Not only an investment in terms of the outcome, but you know the student. That student has become part of your team, and it's like one of your colleagues doing their board exams. You're in there for them. You're waiting for the results to come out with bated breath. So we've actually recruited a whole lot more supervisors, and that's why our tertiary hospital supervisors are saying, we want to do this. We don't know the model, and we've tried 3 models over the last 3 years of how to do it. And the first 2 didn't work very well at all. We tried to copy what other institutions were doing. North American institutions, actually. Very prestigious institutions, actually. I won't give any more details about what they were. But they didn't work. But we learnt enough in that process through studying them to work out what will work in our environment. And our supervisors are saying, we want some of that. We want to have that privilege of knowing some students and actually having the responsibility to transform them from a student into a doctor over that transformative 3rd-year time. So recruiting the supervisors, it's actually been a recruitment boom for our institution.
I Paul, you touched on this, but I was wondering
Who are
if you could, I'm Peggy Plizzard, I'm from General Medicine. Wondered if you could expand a little bit on how this has influenced your research profile at the medical school. You touched a little bit, but have you seen a change?
There's a couple of things. Firstly, we're in the paper a lot more because community people write about us. Not because we're writing about ourselves, but things are happening in other people, and so that the media people suddenly say, "Did you know you were in the paper?" And I go, "No," but we are. So that raises the profile of the institution, which then helps in recruitment. The profile of the research, we have been able to, I think, be part of riding a wave of research that has looked at translational research and particularly implementation science research. So we're a relatively small school in the global context. Are we going to be able to compete with medical science institutions, say of your size, or of Harvard's size, or of Duke's, or those sort of? No. But a lot of that science only gets to here, and the patients are all out here. So there's that type 3 or the implementation science. So it certainly has given us a platform to really engage in implementation science research. We have developed chronic disease self-management research profiles. We've developed research profiles in palliative care. We've developed research in Indigenous health. We've developed research in health services and remote health service models. So yes, absolutely, it's expanded our research profile. Has it diminished what we've done at the Academic Medical Centre? Not at all, because it's all been new money. So it's not a robbing Peter to pay Paul sort of situation. It's actually a growth strategy.
Hi, I'm Susanna Williams. I wondered if you, when you were talking about patient engagement, I wonder if you incorporate any, mind-body techniques, meditative or mindfulness techniques, either with the patients or with your, and when you're training your students.
Yes, I'm aware of the Phrenesis project here and how you've incorporated that. I want to take some of that stuff back. In fact, we're actually getting Avi to come and speak to us from New York about his mindfulness approach with the basic sciences. I'm trying to remember his second name. Someone here may know him from IASME, who does a lot of work in mindfulness. No, we don't, explicitly. However, our students are now engaged to a much wider diaspora of supervisors who all have different approaches to life and different approaches to practice. And our students come from a more diverse base with different life experiences, philosophies, religions, ethics, all of that. It's one of the reasons in the symbiotic medical education model we explicitly say that there is often going to be a tension between the defined professional norms and values and the personal principles of individual clinicians and students. And we want to give students enough time to be able to figure that out, of where they sit. And one of the ways they can figure that out is by getting to know their supervisors as people. Getting to know what makes their supervisors tick and why their supervisors are resilient, beyond a lecture, but actually seeing it in practice. And it's that extended time with the supervisors that gives the students the opportunity to see those sort of things. But I think we still have much to learn from people like yourselves here.
I'm Sean Mead, I'm the director of our Generalist Scholars Program. Thank you for the very inspirational vision of what medical education can and perhaps should look like. I'm curious if you can help us, one of your slides talked about workforce accountability with our graduate medical education dollars. Our thought leaders, including Dr. Fitzhugh-Mullen, has tried for better than a decade to try to move our country away from this culture that we have of the me as opposed to the we. And our politicians, Sebelius, has gone to our leading institutions, Hopkins, and implored them to think about the workforce and the mission of creating a workforce that represents what our country and what our communities need. Are there any lessons from Australia that you could share or personal advice as to how we can somehow advance that dialogue forward?
Yeah, I know Fitz well, and his work, I think, has probably more of an impact globally than it does locally. Happens a lot to us, doesn't it? Prophet's not welcome in his own town, that sort of experience. Our experience has been that we would not have got this, we would not have got the money to do this if we had asked for it. It had to be somebody asking on our behalf. In other words, if the academic community go to government and say, we need support or we need this reorientation to help what we're doing, it's too easily seen as self-serving. You've got an agenda here, what's in it for you, etc., etc., etc. So for us, it had to be people that were perceived to be external demanding it. And what happened in Australia was that rural communities voted out a government. And they said that one of the main reasons was that the health services were not adequate and that the medical education systems to provide those health services were not adequate. So do you think the government listened? They listened very acutely. So it's the political process. This wouldn't have been able to be done if there hadn't been a political imprimatur. As all things, I mean, it's actually mobilising and empowering the community that actually makes this happen. Now, we are thought leaders in that community, and we as educated people from amazing institutions have a responsibility to be thought leaders. But in the end, we don't end up being the spokespeople. Others have to do that for us, and we have to work with those people. So that's a bit of a relinquishing of power for us. It's a collaborative model. Interestingly, many people say that this is going to be the Asian century. We've had a couple of American centuries. We had the European era, we've had the American era. If that indeed turns out to be the case, there will be a more collective approach to decision making and to strategy, which will challenge, I think, a lot of the resistance there's been to change in the United States and the resistance there's been to change in places like Australia. So it'll be interesting to see how those global changes actually play out in the way politicians need to respond. Having said that, you don't need to change the whole of America. We didn't change the whole of Australia. We just looked at one small section of one small school and we saw if it worked, and then we let people watch. And then the revolution occurred, because the politicians need something to be able to grab hold of. And if they can grab hold of something at a reputable institution like the University of Virginia, that really has some miles in it for them.
I'd like to thank Paul Worley for a wonderful hour, and you with all your questions and comments as well. Please join us next week. Actually, Medical Center Hour next week migrates to Friday, not Wednesday. Friday the 11th of March will be also in the Medical Education Auditorium in the Claude Moore Med Ed building for the Richardson Lecture with Sigal Bell, a program called Open Notes, Connecting Patients and Providers to Improve Care and Patient Safety. So we'll hope to see you then next Friday, the 11th. Please join me in thanking Paul Worley.